Assalamualaikum everyone. Today we'll be talking about the tests of ocular alignment. Um, we do this last because these are some of the more, what's the right word for it? The challenging clinical skills to interpret. They are relatively easy to perform, but the interpretation of these tests are pretty challenging, not only for undergraduates, but for many graduate students and even for many practicing ophthalmologists. Before we actually get into the nitty gritty of the test, we'll just go over some definitions. What are these tests of ocular alignment? Well, they are there to determine the presence of and the type of and the amount of ocular misalignment. So, what is ocular misalignment? Misalignment is when both of your eyes are not aligned or straight. When both of your eyes are aligned or straight with respect to one another, that is called orthophoria, and that state is an orthophoric state. When there is a misalignment between the eyes, that term that is then called strabismus, or more colloquially or in plain language, a squint. So the most important background information that you need to have before we actually proceed for these tests is to understand binocular single vision. And that is why when God has given you two eyes, you only see one, because ideally you should be seeing two. The reason for that is both of your eyes are horizontally displaced. There is a horizontal separation between the two eyes, and both of your eyes form slightly different images. And one very simple way of making you understand this is if you're sitting in front of your laptop, or you're sitting in front of anything, and what you need to do is to stretch out one of your hands and stick up your thumb, like giving somebody a thumbs up as in Facebook, but it has to be an outstretched hand, and take any object in front of you that can be covered completely by the top of your thumb. So what I'm doing is I'm covering um, the lettering on the top of my laptop, and what I'm doing it I'm covering it with my thumb and closing one of my eyes, and I'm ensuring that my right eye cannot see those lettering because my thumb is covering. It's essential that you close one of your eyes. I've closed my left eye, and my right eye is looking at the thumb, and the thumb is preventing the right eye from seeing the lettering. So in effect, the thumb is between the lettering and my right eye. Now what I'm going to do once I'm sure I can't see any of the letters is quickly flip between the two eyes. So what I mean by flipping is open my left eye and close my right eye, and my thumb would seem to change positions, although I'm not moving my thumb. Interesting, isn't it? This is because both of your eyes are horizontally displaced and they're looking at an object that you want to look at, i.e., something right in front of you, from slightly different perspectives or different angles. And there is a process by which both of these images, which are slightly different, are processed to produce one image. And that process is basically fusion. And it involves moving your eyes first to basically see what you want to see, which is called motor fusion. And then all the processing that's done in the central nervous system or the cerebral or the visual cortex to take these two slightly different images and fuse them into one. When we do squint, which is also at the very end of the clerkship for very similar reasons, that is one of the more challenging topics to grasp. The reason for it to put it at the end is if you put it at the beginning, there's so many things that are that you should know before you actually understand squint, and we need to cover those first. So the background knowledge that you need to have is that your eyes are separated. They are on the retina of both eyes. The images produced are slightly different, and there is a process called fusion by which these two images are taken together and combined, and that requires coordination between the eyes so that they move properly, which is motor fusion, and then your visual cortex processing the information and producing one image, which is called sensory fusion. Um, and the reason that your eyes remain straight is because they have a stimulus is anything that you want to see, and when they have a stimulus and they are looking at something they want to see, they maintain alignment. So this is the requirement for having binocular single vision. You must have a stimulus so that your eyes are pointed towards that direction, and a loss of stimulus can result in your eye wandering off, as we'll just do in a bit. Then you should have intact motor control so that you can actually point your eyes towards what you want to look at. And then you should have sensory control so that the information taken from the retina, the image produced on the retina, to be fused together in the visual cortex. So the motor control of the eyes, which moves the eyes to make sure that you're looking at the same object, both of the eyes are looking at the same object, is called motor fusion. And the processing that takes place in the visual cortex is called sensory fusion. Again, both of these topics would be covered in greater detail when we talk about squint. So this is the stimulus in this case, and for these two eyes, which is a rose or a flower if it's not a rose. So the stimulus is this, and the eyes are sort of moving, they're converging because the rose is closer. So this is motor fusion, which is your eyes moving and working together to see the rose. And this information is carried all the way to the visual cortex through the visual pathways. And here we have sensory fusion, so that these eyes, which are looking at a rose from slightly different angles and producing a slightly different image on the retina, and as we confirm by doing the dancing thumb test at the beginning. So these slightly different images are taken by the visual cortex, and they sort of create one image from it. So this is what binocular single fusion is. So for these tests, you require a room large enough so that the patient or your subject is able to focus for a distance target. We usually consider 6 meters to be okay. Obviously, when you're doing this test, you'll be provided with the appropriate logistics. You need a torch, you should have your own, and you need an occluder. Um, Generally, an occluder is available at the station, but you should have your own, and you don't need a fancy occluder. A plain card about the size of a postcard, which has nothing printed on it and is really plain, would just do fine. Ideally, something that's of a neutral color. You don't want something funky or some pattern printed on it, because the eye then tends to focus on it. So before we go on and test, we need to understand certain terminologies related to squint so that we can record our findings. And that is, we should understand the types of squint, and they are basically forias. Forias are latent squint. And just like latent hypermetropia, this squint is hidden as long as both your eyes are open. And they are only apparent when you close one of your eyes. And the reason for that is when you close one of your eyes, that the eye that is under the cover is receiving no stimulus. And when it's not receiving any stimulus, it can sort of wander off and deviate. So that implies that many normal people would have aphoria, and yes, they do, as we'll just see when we do our clinical skill testing. But the reason that we do foria testing is because there are many types of squint that start off as aphoria and then become atropia. And again, more of this discussion happens when we talk about squint in general. The other type is called atropia. This is a manifest squint. This is something that's visible when both your eyes are open under binocular seeing conditions. There are many causes of tropias, some of which we'll cover again when we talk about squint at the terminal end of the clerkship. But as you can see, as you would have probably noticed, your eye can move in various directions. So that deviation can also be in various directions. And the terms used to indicate the direction of deviation for both tropias and forias are as follows. If your eye is deviating inwards, it's called an esotropia or esophoria. If your eye is deviating outwards, it's called exophoria or exotropia, depending you're looking at a latent or a manifest squint. Downwards is hypo, deviation above is hyper. So these are the terms that we use in order to tell in which direction is the eye deviating. And if you take an example that the patient's right eye is deviated inwards, that would be called right esotropia. And if a latent squint is detected and the eye is turned inwards, that is then called esophoria. We'll do latent squint or testing for latent squint, how these things are picked up. But the message here is, depending upon where the eye is turned, we use these prefixes, and then we just attach tropia or phoria as a postfix, depending upon what you are seeing or what you are checking. So what tests are we going to do? For an undergraduate, we do two tests. The first is called a corneal reflection test, also called a Hirschberg's test. And this is for detecting the presence of squint and quantifying the squint or alignment. Meaning, if a squint is present, and if it's present, how much of it is present, putting a number next to it. The other tests we do, which are sort of more challenging to understand, are cover and uncover tests. And these again help in detecting a squint and also qualifying a squint. What we mean by qualifying a squint, we'll talk about when we talk about these specific tests. So corneal reflection test is really a simple test. And this test depends upon you having a torchlight and seeing the reflex of the light bulb on the cornea, something sort of similar to what we did when we were doing ptosis testing and we were looking for marginal reflex distance. For this, you need to have two things in your subject or your patient. Your pupil should be of normal size. They should not have drugs in their eyes or any other region for which the size becomes abnormal. So you should have a round and a normally sized pupil. Anything else makes this test sort of difficult. And you should be able to look at the pupil. So your cornea should be clear enough so that you can gaze inside your anterior chamber. So what is Hirschberg? Hirschberg basically implies you having a torch, shining a torch at the bridge of the nose with a torch that's horizontal, just like we talked about when we talked about squint. You can't have light that is oblique. So if this fist is my eyeball and my eye bridge of the nose, sorry. So this is the bridge of the nose. So your light is horizontal with the bridge of the nose. It's not obliquely directed because that changes the position of the reflex. So it is straight. I hope you can see the torch. I am sure you could see now because it's right in front of the camera. And it is at the bridge of the nose. It's not like this. It's not moved in the horizontal or the vertical axis. It's at the bridge of the nose, and it's not obliquely shown into the eyes. Um, so once you have these prerequisites and you're shining the light, a prerequisite meaning a clear cornea and a normal round pupil, which and you have your torch at the bridge of the nose and you turn your torch on, you really don't need to dim the room lights because this can be done really well, and it's actually much easier to see the pupil when the lights are on. It's very difficult to see the pupil when the lights are off, so you do this in normal light. So what we are doing is we are basically interpreting the corneal reflection of the light bulb. I'll also call it reflex or reflection interchangeably. So here they mean the same thing. So right, for example here. So this is the light reflex or the reflection of the light from the torch. And normally when it's shining at the bridge of the nose and your eye is straight, this light reflex corresponds to the center of the pupil. I'll show you some pictures. If this light reflex is not corresponding to the center of the pupil, that means your eye is no longer aligned and is deviated like it's shown in this eye, the left eye. The light reflex has moved temporally outwards or laterally from the center of the pupil, which is right here represented by where this line is and my pointer. So this is the gap. This little distance is the distance between the center of the pupil and where my light reflex is. The light reflex has moved outwards and the eyeball has rotated inwards. And this is very easy to understand because the motion is relative. When the eye is moving inwards, the reflex would relatively move outwards. So we have figured out two things right now. We have determined that their eye is not straight and that the eye has moved inwards. And it has moved inwards when both of the eyes are open. So we know that this is an esotropia. All we need to figure out is how much of esotropia. Remember, we are going to quantify put a number next to the deviations. Okay, so let's quantify our squint. We've already determined that the light reflex has moved outwards temporally or laterally, while the eyeball has rotated inwards, medially or nasally. And the reason that the light reflex goes in the opposite direction is because the movement between the eye and the torch is relative. The torch is static, not moving, because your right reflex is in the same position and the eye is only moving. This is best observed by doing it yourself in somebody at your home. Shine the light at the bridge of the nose, as we already discussed before, and just ask him to slowly move your eyes, very slowly, fine movement, so you see how the light reflex moves when your eye moves, and the light reflex movement is opposite to the movement of the eye. So in this case, the light reflex has moved temporally, laterally, or nasally, outwards. So the eye has moved medially inwards or nasally, so that we now know this is an esotropia because we've already done the terminology. The eye has moved esotropia, we're just putting a number. And the number right now that we have is that the light reflex has moved 2 millimeters or deviated 2 millimeters outwards or laterally or temporally. Use either one of these two words. Don't say all three. Say the light reflex has moved 2 millimeters lateral or temporal or outwards. Just one, not all three. So let's and because just like on visual fields we were measuring the position or the of the scotomas in degrees, or the visual field was measured in degrees, the deviation is also measured in degrees because your eyeball is rotating, and rotatory distances are measured in degrees, just like when you were doing circles and stuff. So we need to convert this number into a degree so that we can determine in terms of angle how much of the eye is not straight anymore. So what we do is we have already determined here this part that the light reflex has moved 2 millimeters laterally, and we know that from the center of the pupil. So this yellow circle is the center of the pupil. And we also know that the radius of a pupil under brightly lit conditions is about 4 millimeters, the diameter, sorry. So the radius is 2 millimeters. And we also know now that the information I'm adding that every millimeter of deviation, irrespective of direction, light deviated outwards, upwards, downwards, nasally, medially, laterally, superiorly, inferiorly, whatever, equals 7 degrees of deviation. So our light reflex had deviated 2 millimeters. So 2 multiplied by 7 is 14 degrees or 15 degrees. Both numbers are okay. If you have a very picky examiner, say 14 degrees. If you have me, even 15 is fine because these are all approximations to begin with anyways. So we converted our number in millimeters to degrees by multiplying that number by 7 because every millimeter of deviation approximates to about 7 degrees of deviation. And we've already determined that because the light reflex had moved temporally, the eyeball relatively moved inward, and because the squint is defined on the position of the eyeball, this is an esotropia. It's a tropia because we picked up this squint when both eyes were open. Remember our diagram initially? So this is an esotropia of 15 degrees, and the light reflex had deviated temporarily by about 2 millimeters. So in order to make this slightly easier, there are certain benchmark positions that I'll just discuss. Benchmark positions is you shine the light at the bridge of the nose and you quickly just pick up where the light reflex is. And if you remember these benchmark positions, you'll just come up with the deviation in degrees rather than multiplying in your head. Why do I say these? Because these three positions that I'll describe are the most common that you see in a corneal reflection test. I emphasize most common. You can see other positions, but these are the most common ones, and common things happen commonly. So these are the three most common uh, degrees of deviation that you usually see. So what are these three? Remember, this big light in the center is the center of the pupil. So if your corneal reflection is centered on the pupil, that means no deviation. Very good. You are pretty much done with your station, but you don't obviously get a patient with straight eyes, and you will not be asked to do a corneal reflection test on him, hopefully. So the first possibility is corneal reflects at the edge of the pupil, which is 2 millimeters away. We have already done why that is. This red dotted line is showing you the diameter of the pupil, which is 4 millimeters. So because we are measuring distances from the center, we are going to consider the radius, which is 2, half of 4 is 2. So the light is deviated 2 millimeters away. The second possibility is the light has deviated midway between the center of the pupil and the limbus. Now, one thing is, as you can see here, the center of the pupil and center of the cornea are sort of at the same point. And that is why I said in the beginning, you need to have a normal round pupil together with a clear cornea in order to do this test. So when you're shining the light at the bridge of the nose in a normal person, the corneal reflection of the light that you see centered on the pupil is also indicating the center of the cornea. So this yellow line, which is the diameter of the cornea, is telling you that if your light is midway between the center of the pupil and the limbus, it's moved about 3 millimeters. And how do we know that? It's because this is the center of the pupil as well as the center of the cornea, as we just discovered. And if we start counting outwards from this point towards the limbus, we are walking on the radius of the cornea. And because the diameter of the cornea is 12, the radius of the cornea is 6. And we are midway between the center and the limbus, and limbus is the termination. So between the center and the limbus is 6 divided by 2, which is 3 millimeters. So if you see a light reflex falling somewhere in the middle of the center of the pupil and the cornea, as we just determined it's the same, and the limbus, the deviation is about 3 millimeters. And finally, if you see the deviation, the light reflects at the limbus, that means it's moved 6 millimeters from the center because that's the radius of the cornea. So these three positions, 2 millimeters, 3 millimeters, and 6 millimeters, are the most common. So you can remember the most common deviations are 14, 21, and 42 degrees. I hope you know how that was, because 2 multiplied by 7 is 14, 3 multiplied by 7 is 21, and 6 multiplied by 7 is 42. As I said, these are the most common deviations, but not the only deviations. And because at undergraduate level, we only talk about horizontal deviations, so you'll be seeing exotropias or esotropias. Exotropia, I am moving outward, esotropia, I am moving inward. So let's do this picture. This is an Asian dude just like us. And the reason I put up this picture is because although these diagrams are really nice, in reality, things don't stand out as well as here. They stand out something like this. And for a minute, you really have to focus on the picture to see where the hell is the pupil. And the pupil is difficult to pick up because our color tone and our irises are so darkly pigmented that they are very close to the color of the pupil, which is grayish green. And you're going, yeah, pupil guy. But if you look carefully, you can actually see the pupil, and you can see that this pupil, the corneal reflex is centered on the pupil. Thus, these eyes are orthophoric or straight. Let me give you Agora eyes or Caucasian eyes and see how easy things are because of their difference in contrast and color tones. That the left eye, the corneal reflex is centered on the pupil, eye is straight, no squint. But here, the corneal reflex is at the edge of the pupil, and the reflex has moved inwards towards the nose or medially. So the eye has deviated outwards, laterally or temporally. So when the eye is deviated outwards, it's called exotropia. And we know that if it is at the edge of the pupil, it's 2 millimeters. And we know that we need to multiply it by 7 to get our answer in degrees. So this is 14 degrees of exotropia in the right eye. But we need to deal with these individuals if you deal with, people living in Asia. Well, most of the people of our descent are this colored, irrespective of where we go. So these are some possibilities, and they're from your clerkship manual, and they're just reproduced here for, repetition's sake. So these are straight eyes. The corneal reflex is centered on the pupil. It is 2 millimeter deviated outwards, so the eye has moved inwards. So this is 14 degrees of esotropia. This is deviated at the limbus. So this is about 6 millimeters, 42 degrees. And if it is possible for the eye to have a greater deviation, then you just say that the eye has deviated by more than 42 degrees if the corneal reflex is moved beyond the limbus. Obviously, when I talk about beyond the limbus, it's not moving towards the center of the cornea, it's moving way away from the cornea altogether. In all these cases, the right eye is straight as the left eye is deviating to various degrees. So now we're going to be talking about the other test of ocular alignment, which is the cover and uncover test. The cover test is basically to detect and qualify atropia. Atropia is a squint that's visible when both of your eyes are open. An uncover test is designed to detect and qualify aphoria. Aphoria was a squint that was picked up when you remove the visual stimulus from the eye, so that both eyes are not looking together. There is no binocular vision. And this eye, because it has no visual stimulation, it has the opportunity to move about simply because it is the visual stimulation that keeps your eye straight, as we talked about the prerequisites for maintaining good binocular vision. That also means that phoria is seen in normal individuals. So let's talk about the cover test, and the general description is here. A more elaborate description is in your clerkship manual. And this is basically to pick up atropia. And how you do it is you are looking at a patient, because not all the time that you are asked to do an ocular alignment test, you begin with a corneal reflection. Sometimes you're asked only to do the corneal reflection test and give your findings. Sometimes you're only asked to do cover and cover test and give your findings. So if you're starting from a cover and cover test and you don't know whether there was any pre-existing deviation because you didn't do the corneal reflection test or the Hirschberg test, the first thing you do when you sit down is to look at the patient and see if there is any obvious deviation. If you see any obvious deviation, you cover the good eye. By good eye, I'm meaning the straight eye, and see what the bad eye does. See the behavior of the bad eye. By bad eye, I mean the deviating eye. Because we want to qualify the tropia now. And what does behavior mean? I'll just talk about in a bit. And then you repeat the process for the other eye. But what if you're doing this test in a person who has no apparent squint, and the person or your examiner or your faculty member just wants to check your method? Like we do when you do it at home, you start by covering the left eye to see the behavior of the right eye, and then you reverse the process. Obviously, when you're doing it on a normal individual and you're covering the left eye, and the right eye was straight to begin with, the right eye is not going to do anything. But we would at least know you know how to cover, where to tell the patient to look, and where are your own eyes looking. Doing the method is halfway there because then only the interpretation is left. So even if you're asked to do it in a normal person in which none of the eyes are deviating to begin with, you cover the left eye to see what the right eye does. And obviously in a normal individual, the right eye won't do anything, but we'll know you know how to do the method properly. If you're properly covering the eye, the patient is gazing or looking properly, and your eyes are also looking properly towards the patient. And once you have done this for one eye, you do this for the other eye. If both eyes were straight, start by covering the left eye, do the right eye first, then cover the right eye to do the left eye second. If you see an obvious deviation, cover the good eye or the straight eye, see what the other eye does, and then repeat for the other eye. So this is the general interpretation, and as I said, the most important aspect is to check the behavior of the deviating eye. What does it do when you cover the good eye? Because that's the entire point of the test. Qualify atropia. So when you cover the good eye, see what the bad eye does. The bad eye can do two things. The bad eye meaning the deviating eye. It can either become straight and take up fixation, which would mean two things. One, there is visual potential in this eye. That is why it started seeing or become it became straight. It became straight because it started responding to the stimulus, which it wasn't when both eyes are open. Why that is, we'll do that when we talk about squint at the end of the clerkship. The other possibility is that you cover the good eye and the bad eye does nothing. And that would imply that the motor control of this eye is bad, or this eye has become so amblyopic. And we've talked about certain causes of amblyopia. We'll talk about one more cause of amblyopia when we do squint. This eye has become so amblyopic that it has no visual potential, it can't see. So if this eye moved to take up fixation, it would mean one, it has visual potential. Two, the motor control is fine because the nerve and muscles are working. That is why the eye became straight. If the eye doesn't mean, it again means two things. Either the motor control is faulty, so that the eye couldn't move or budge, nerve or muscle, or both are damaged, or the eye has become so poor in vision that it can't see anything when you cover the good eye and it one just sticks out. How do you differentiate between the two things? We're going to talk about in a bit.
So, in order to make this entire topic of ocular alignment skills, I decided to add this video. Unfortunately, I couldn't find any in our archive, so I borrowed this video from the internet. It's not mine, it's from North America. But it demonstrates very well the cover part of the cover and cover test. The uncover part, you'll see we have our own video, but for the cover part, we'll use this video. And the first case is that of esotropia. Esotropia is when both eyes are open in under binocular viewing conditions, the eye is deviated inward and the left eye is deviated inward. Now you might say that the reflex in right eye is not central. It's because of the way the face is oriented. But here it's the left eye that's deviated inwards. And as per the instructions of cover part of cover and cover test, we cover the good eye, the straight eye, to see what the deviating eye does. So the examiner will cover the right eye. Sorry. And let's see what the left eye does. Here we go. So the left eye picks up fixation. It straightens, which is telling us two things again. A, this eye has visual potential. It is able to see. And B, the nerve and the muscle, the motor control of this eye is intact. So this is the cover part of cover and cover test. Now what the examiner will do is cover the other eye, because remember when we are doing the cover part of cover and cover test, we need to do it for both eyes. So now what he will do is cover the other eye, but the right eye does nothing. It does nothing because it was straight to begin with. So really, when you cover the deviating eye, the good eye that was straight to begin with does not show any movement simply because it was straight before, it's going to be straight after. So we are going to now take on an patient who has an outward deviation, and this is pretty clear. This eye is straight, and this eye is deviated and deviated outwards. So we are going to cover the right eye, the good eye, to see what the deviating eye does. So as you can see, just like before, when we covered the good eye, the deviating eye again picks up fixation, becomes straight, which is again telling us two things. One, it has visual potential, and two, the nerve and the muscle, the motor control of this eye is intact. And now when we flip, now you might see when the cover is removed, this eye seems to be deviated outwards. And that's just a response of the other eye picking up fixation when the cover is in front of this eye. But as soon as the eye has time to go under binocular conditions, this eye becomes straight. So when we cover this eye shows no movement, it has no squint. So what the purpose of this video was to show you how an eye that is deviating behaves when the good eye is covered. It does not demonstrate the behavior when the motor control is not intact or the eye is amblyopic enough. But in that case, this eye will not show any movement. So I hope this makes it a little easier to understand the cover part of the cover uncover tests.
So now we will talk about the uncover test. And uncover test is basically to detect aphoria. Remember, aphoria only happens when you take away the visual stimulus. So the eye that is behind the cover has an opportunity to wander about because it's no longer being stimulated. And how you do that is, obviously, you start off with a cover test and you're covering the good eye. And when you are uncovering the good eye, you also check the behavior of the eye as the cover is being removed. So you're performing the uncover part right after the cover part. But when you're doing the cover and uncover test, what the examiner is looking at, especially for the uncover test, is did you leave the cover in front of the eye long enough? You can't just go cover, see what the bad eye is doing in 2 seconds, and uncover, see the uncover test for the good eye. And that is because of a phenomena called latency. See, in your retina, an image must be kept on your retina for about 1/10 of a second or 0.1 seconds for it to reach this visual cortex and be processed. So a retina would not register a new image if one was presented to it before 1/10 of a second, because that is the latency required for processing this image. And those who play games know latency very well because they know frame times and frame rates and know how important it is. And taking advantage of this phenomena is how full motion video was created. You know, when you talk about Oscar awards, they talk about motion picture, because they talk about pictures with motion, not those still pictures. And that works because a new image is presented to our retina before 1/10 of a second, so you have an illusion of smooth motion. And the more frames that are presented, the smoother the motion. And that is why you have those fancy 240 hertz monitors for those Twitch responder Fortnite players or sports fans, because you really, really want that low latency illusion in order to get that fluid motion sense in front of your eyes. Anyways, so make sure you keep the cover in front of the eye for 10 seconds and remove the cover to see what the eye behind the cover was doing. And remember, aphoria can happen in a normal person. So if you have a normal person sitting in a nosky and the examiner is asking you to do a cover and cover test, obviously he knows when you're doing a cover test, you will not have any information for the cover part because the eye was straight. But you can have an information for the uncover part. So don't assume that this patient is normal. He might have aphoria. So you cover the eye, and because this is a continuation of the cover test, you always begin by covering the good eye, so to observe the behavior of the bad eye or the deviating eye. But the uncover part is actually going to tell you what the good eye was doing. So you uncover after 10 seconds and you see the behavior of the eye coming out of the cover. And then you repeat the procedure for the other eye. Now, what do I mean by behavior? I mean by behavior is that, remember, the eye behind the cover can have aphoria normally. So when their cover is removed, it can, in normal circumstances, a person who had no squint otherwise, 99% of the time will become straight to take up fixation and it will move. If the eye had gone outwards behind the cover, moved laterally or outwards, that means the eye has an exophoria. But when you remove the cover, eye would move medially or inwards to take up fixation to see again. And a normal eye would do that because a normal eye would just fixate again, as I'll just show you in a video. But it is possible to have aphoria and atropia together. So if you were covering an eye which already had atropia and you're uncovering it and you detect movement, that means an eye also had phoria on it. And depending upon where the eye moved behind the cover would tell you exophoria tha Isophoria tha. You don't quantify phorias, you only qualify phorias. And sometimes it is also possible for to begin with straight eyes when you're doing cover and cover test, orthophoria. But when you cover an eye, it deviates, and when you remove the cover, it doesn't go back. This is a phoria that can break down into atropia. And we will talk about this when we talk about squint at the end of the clerkship. That is why I said cover and cover test can be challenging. There is more detail in your clerkship manual, so you can sort of read it up from there to have a better understanding of what I'm talking about. So I'll just show you some videos showing exophoria, and this is a normal speed video and then a slow-mo video. So we'll see a normal speed video and see if you can pick up what I'm talking about. Wait for it. Ah, did you see that? Let's see it once more. Once more for the row. Notice the eye moving inwards as I remove the cover. If the eye is moving inwards, where was the eye behind the cover? Outwards. So if the eye has deviated outwards behind the cover, this is an exophoria. The corrective movement is inwards because as soon as I remove the cover, the eye gets the visual stimulation and it aligns with the other eye and becomes straight because we began with normal eyes. I didn't show you the normal one, but we began with normal eyes. And you can see the eyes are normal because they are straight right now. Let's see it in slow-mo. See the eye move towards the center. It's actually easier seeing it in fast mo or normal mo than slow mo. But this is how an exophoria is picked up, and it's so essential to really pay attention to the eye from which the cover is being removed, because if you're paying attention to the other eye, you'll miss it altogether. I was looking at my right eye and I miss it altogether. You're supposed to be looking at eye behind the cover when you do look for a phoria. And yes, the other eye would also show a small movement, and that's just a corrective movement to align itself with the eye coming out of the cover. Because for that split second, this eye, the eye behind the cover was deviated outwards. So in order to be straight, the eye that was uncovered also deviates a little bit inward so that both eyes are pointing in the same direction. But because the patient was looking straight, as soon as the eye behind the cover becomes straight, the other eye also picks up, becomes straight. That's why I say this is challenging. If you didn't understand the last bit, or if you did pick up a little bit of movement in the right eye when the cover in this eye was removed, that is because remember, yeah, I can pause it. I'll just show you. This eye had moved outwards behind the cover. So as soon as I moved the cover, there was inwards movement of the eye. And because as soon as the cover is removed, this eye has a visual stimulus. And in order to maintain alignment, this eye moves inwards a little bit initially so that it aligns itself with this eye. But because this eye is going to become straight eventually, because that's where you're looking at, both eyes become straight. And this is something that is normal. I hope you understood this. That's why I'm saying this is challenging. If you don't, we can have a face-to-face in this, and I can explain you this. But an undergraduate was only asked to explain the behavior of the eye undercover on doing the uncover test and explain what type of phoria it was. And the most common mistake made is that you would say the phoria in the direction in which the eye is moving. For example, the eye is moving inward. You say this is esophoria. This is not esophoria. This is exophoria because the eye behind the cover had moved out. The corrective movement is inwards. And remember, it's not the corrective movement that qualifies a squint. It is the deviation of the eye that qualifies a squint, and the eye had deviated laterally or outwards, thus exophoria, because this was happening behind the cover. So how do we record our findings? First, we'll talk about recording findings of the corneal reflection test, and those are really easy. If both eyes are straight, you write both eyes are orthophoric aligned. If you have a deviation that you see, you say right or left eye, and then you mention the type of deviation, the position of the reflex, and amount of deviation. For example, if the right eye had an exotropy of 21 degrees, you also note reflex deviated nasally 7 millimeters. This gets you an extra credit, a little bit of credit, but extra credit. And remember, the deviation of the reflex is opposite to the deviation of the eye. So the corneal reflex had moved inwards, so the eye had rotated outwards. So for cover uncover test, we'll talk about cover test first. You write which eye, right or left eye, the type of deviation, and mention whether the eye takes up fixation. Remember, this is for the eye that is visible. This is not for the eye under the cover. So for right eye, if you see a right exotropia and you do a cover uncover test and the right eye picks up fixation, you cover the left eye. The right eye was exotropic before you did the test, and when you covered the eye became straight, picked up fixation. You say it takes up fixation on covering left eye. For the uncovered test, you mention again the eye, and then you are doing this for the eye that is coming out of the cover. Remember that. So if it has an esophoria, say right eye esophoria. If the eye under the cover, and remember we said the eye under the cover has an opportunity to not move and move a lot. And remember, it is the eye that is coming out of the cover that is what we are looking at. So for example, you had patient is looking straight and he had right eye exotropia to begin with. And you are checking for a phoria in the left eye. So this eye had an exotropia and it did not move on doing a cover test. So this stuck outwards. It had two possibilities then. Either this was amblyopic, wasn't fixing a fixation, or something went wrong with the medial rectus or the third nerve, because that's the muscle and that's the nerve that makes the eye move inwards. So you're doing the uncovered test for the eye that was straight. And when you are uncovering the eye and you see this eye had moved inwards more than this eye had, then this eye, which did not move when the good eye was covered, has a paralytic squint. And this is called a secondary deviation, primary than a primary deviation. And again, the details for this are in the clerkship manual, and we'll discuss this again when we talk about squint at the end. And if you have questions as to why that is, you can ask them. But basically, this is because this eye wants to be straight. It can't be straight because the nerve and muscle are not working. So the brain is sending impulses to make this eye straight when this eye is blocked, because this is the only seeing eye. Then it wants to go be straight, and it's not going to become straight because the nerve or the muscle is dead. And because the same signals are coming to this eye, the medial rectus of this eye is super stimulated, and under the cover it turns inwards even more than this eye because this nerve and muscle can work. So that's called a secondary deviation more than a primary deviation. Again, squint is challenging as an assessment of squint. And picking up phoria is really something that you really need to be observant, as we saw when we were talking about, when we saw the video. So this is all about cover and cover test. And I apologize if I can't really simplify this for you beyond what I have. I apologize for it because this is a really challenging thing to do and to interpret all the different possibilities. We try and keep it really simple for undergraduates, but if you still have any questions, please do ask. WhatsApp group. You want to do a face-to-face on this, please do it, because this potentially can come in an assessment. So you need to be at least competent enough to pick up basic tropias and phorias, and also do a proper corneal reflection test. At undergraduate level, we don't give you a paralytic squint to detect a secondary deviation greater than a primary deviation, but it's always good to know because it can come in an MCQ. And an assessor on an OSCE station, although not required to ask you this, can ask you this if you're doing really well. So if you know this, you might just make him happier. And making examiners happier is never a bad idea. So thank you very much. Now we will see the method, and we will record the findings of the method at the end. Thank you. Bye-bye.
अस्सलाम वालेकुम। मेरा नाम डॉक्टर अली है। आज मैं एक टॉर्च की मदद से आपकी आंखों के पट्टों का मुआयना करूंगा। मुआयने के दौरान आपको कोई दर्द या तकलीफ नहीं होगी। अगर आपको कोई दर्द या तकलीफ हो तो आप ज़रूर बताइएगा, ठीक है। दोनों आंखें खोल के सामने जो हर्फ लिखा हुआ है सबसे ऊपर आपको नज़र आता है जी, उसकी तरफ देखिएगा। So the first thing that we do when we're doing ocular alignment is the corneal reflection test, which is basically shining a torchlight at the bridge of the nose and noticing the position of the corneal reflex in both the eyes. the actual recording of the findings would be explained at the end. ठीक है, अब आपने करना ये है कि इसके ऊपर जो पेंसिल के ऊपर रबर लगा है इसको देखें, रबर को देखते रहें. So bring in a near target at the bridge of a nose about 30 centimeters from the eyes, making sure it's central. Again, note the corneal reflex, or the corneal reflection is a better term. This is also called the Hirschberg test. ठीक है, आपका बहुत बहुत शुक्रिया. अब आप सामने दोबारा देखेंगी, मैं इस कार्ड की मदद से आपकी आंखों को बारी बारी बंद करूंगा. ठीक है, सामने सीधा देखती रहें. So the other part is the cover uncover test. You might be asked to perform the corneal reflection test or the cover uncover test or both of them during your OSCE stations. सामने सीधा देखते रहिएगा. So for the cover uncover test, we are going to cover the right eye, observing the behavior of the left eye, which is the cover test. मैं इस कार्ड की मदद से आपकी दाई आंख को बंद करूंगा. सामने सीधा देखते रहें. We are doing it जो सबसे ऊपर हार्फ लिखा हुआ है. So we cover the eye and we observe the behavior of the uncovered eye. Does the uncovered eye move? And if so, in which direction? The uncover part of the cover and cover test involves covering the eye for at least 10 seconds. And as we remove the cover, we see the behavior of the eye and any movement in the covered eye. सामने सीधा देखते रहें. One way of making sure that 10 seconds have passed is to say 1 1000, 2 1000, all the way to 10 1000. सामने सीधा देखिएगा. I'm going to remove the cover, and right now the examiner is noticing where your eyes are, at the uncovered eye or the covered eye. Your eye should be looking at the covered eye to see its behavior. ठीक है, इसी तरह से मैं आपकी दूसरी आंख को बंद करूंगा. We are going to check the cover test in the left eye. So bring the cover in front of the left eye, observe the behavior of the uncovered eye. Does it move, and if so, in which direction? Again, wait for 10 seconds before uncovering the eye. So you can count 1 1000 to 10 1000. And on uncovering, note the behavior of the eye under the cover. Again, the examiner is focusing where your eyes are looking. Your eyes should be focused on the eye that is right now behind the cover. आपका बहुत बहुत शुक्रिया.